morning. My name is Jim Holt. I'm one of the faculty at ETSU Family Medicine in Johnson City, and I was asked to give a kind of overview of care of complex patients over a long career. I've been in practice for more than 30 years. So I'd like to start by looking at patients that I've seen along the way, situations that I've encountered. Started out in family medicine only, grew into geriatrics, got boarded in geriatrics. So I've seen complex patients at every stage of my career, including residency. As a resident, I first saw SP, 35-year-old mother of two, who was unable to work due to disabling back pain. She was a single mother and was having trouble getting along. Despite extensive research, I was frustrated that nothing seemed to really help. Unfortunately, the research backs up that nothing really helps in back pain. The usual treatments are ineffective. I also saw LD, who lived in an upstairs bedroom in a housing project. When I first saw her, she was blind and all alone, with all the doors to her apartment open to the street. I managed her diabetes and heart failure and other active conditions through home visits. However, I really couldn't change her high-risk surroundings. After residency, I worked in a rural health clinic set up in the hospital, which had just closed in a town of 900 people. I saw people who had lacked access to care for years. Like DW, who was over 400 pounds and hadn't seen a doctor in years. I diagnosed her with diabetes and hypertension during her visit, but then she slid to the floor and we couldn't get her up. It took EMS and half our staff to get her up so that she could go to the ER. After 3 years in the small town of 900, I joined 3 established family docs in a town of 9,000. We shared hospital patients, and I gravitated towards treating the sickest of the patients in the hospital and the oldest. It amazed me how often cutting out several high-risk medications would clear delirium. My nurse, Sarah, came to know how I would handle most situations, and she handled them. This was my first effective team apart from working with other docs. I saw Barbara, a patient with previously undiagnosed histrionic personality disorder. Every visit, she'd have at least one serious complaint, described dramatically. I wonder if I missed something important. Barbara died suddenly while she was out of town. I also began feeling the call to teach. I began precepting a half day every month in Charlotte, and I really enjoyed it. The experience reminded me how difficult and complex patients are who join residency clinic practices. In 2001, I joined the faculty here as medical director and soon took over the geriatrics training also. As medical director, I called patients who complained about their care. One of my first highly complex patients, DJ, joined my practice after I handled his complaint. He was a past city councilman and a current alcoholic. I cared for him off and on, and he drank off and on for 12 years. I knew he would die quickly after he developed dementia, and he did. EW is a typical complex geriatrics patient. She was taking over 20 meds when I first met her for 8 major chronic diseases. She is consistently anxious and depressed, likely from mixed bipolar disorder. After caring for EW for 15 years, she has now developed early dementia. Her ability to care for herself has diminished. She's been hospitalized twice in the past 6 months. I really hate to witness her decline. Here at ETSU Family Medicine, we truly have developed a functional care team. Leona, our nurse, Jody, our behavioralist, Alicia, our social services person, Ryan, our PharmD, and I lead a team, also including students in several disciplines. Also, our transitional care clinic for recently discharged hospital patients plans and executes multidisciplinary visits. We have a QI team to improve our care of the most complex patients in our practice.